Good afternoon, ladies and gentlemen. At the outset, I must congratulate and thank Dr. Sanjay Agarwal, Dr. Neeta Deshpande, Vijay Neglur, and their entire team for putting up such a wonderful academic feast here and a wonderful hospitality. The topic given to me is CV outcomes and adherence with GLP-1 receptor agonist, making the comparison. Diabetes and CV disease. Ultimately, diabetic patients die of a cardiovascular disease. Almost 2/3 of them will die of a cardiovascular disease or a macrovascular disease. So diabetes, CV disease is a major cause of mortality and morbidity in patients with diabetes. We have had cardiovascular outcome trials for all the drugs after the rosiglitazone fiasco. And it has been a US FDA mandate that any new drug introduced should have cardiovascular outcome data. So there are data from cardiovascular outcome trials on GNP1, which has been released and continue to emerge. There are many more trials in the pipeline. You have, the first one was Excel, which used once weekly exenatide, Leader once daily liraglutide, Sustain 6 once weekly semaglutide, ELISA once daily lexanatide, Harmony with albiglutide. Freedom CVO was an implantable exenatide. And recently at the ADA, 9th of June, once weekly dulaglutide. These were the studies that have been presented to us. Let us look at the Excel. This was the first one. It was exenatide once weekly. It was the largest, most inclusive patient population for any cardiovascular outcome trial with GLP conducted to date. 14,000 plus patients, 687 trial sites across 35 countries, and the primary prevention, it enrolled predominantly patients with established cardiovascular disease as well as a population that did not have cardiovascular disease. And what did they find? That it was safe. It was not causing any problem. What they were looking for, most of the studies at that time, was whether there was any risk of cardiovascular complications using these drugs. So as far as superiority is concerned, exenatide was not proven to be superior in the Excel study, but in primary outcome, non-inferiority, it was matching. There was no cardiovascular danger with this drug. So as far as the post hoc analysis of Excel was, there was no substantial increase in pancreatitis, pancreatic cancer. This is what was always thought of, that GLP-1, DPP-4 can cause pancreatitis, pancreatic cancer, and so on, but that was not to be. Though thyroid papillary carcinoma, numerically, you had 10 cases out of 14,000 which were done, and 4 in the placebo group. This is absolutely not statistically significant, but this is what had happened. What would be the clinical application of results from Excel? Excel had enrolled a very broad population as part of the routine care and sought to understand the effect of once weekly exenatide in patients with prevalent cardiovascular disease. CV superiority was slightly demonstrated with once weekly exenatide, and in 2018, EMA approved the update to label to include the favorable CV safety profile of once weekly exenatide in patients with type 2 diabetes. Now let us look at Sustain 6. Rajiv Koil before me spoke about the oral semaglutide. This is the Sustain 6, very interesting, short trial to see, look for cardiovascular safety, just 3,000 patients, short duration, but it showed that it was not inferior, it was cardiac safe, but at the same time it showed that it was superior. Non-fatal strokes reduced significantly, non-fatal myocardial infarction, but death from all causes was neutral. Stroke and primary outcomes did show a very significant improvement. And there was also a significant reduction in new or worsening nephropathy. So here now you had an angle that a GLP-1 could be kidney friendly. Then came the Leader trial, once daily liraglutide, and this significantly reduced cardiovascular death as well as non-fatal MI and non-fatal stroke compared with placebo. This was a very well-conducted, extensive study over 3.8 years because the US FDA said minimum 3.5 years study. So they had lot of events happening in this study, and it gave a good outcome. Look at the primary composite endpoints. Significant p-value there. Cardiovascular death, very significant. Death from any cause, significant. Fatal, non-fatal MI. So P was 0.001 for non-inferiority and again for superiority. So it was a drug which was shown that obviously no cardiovascular problems, but it was benefiting cardiovascular death and death from any cause, and fatal and non-fatal MI. And look at this 3-point maze. And what I want you to see here is that there was a 13% risk reduction versus placebo. But look at this. The separation really starts almost at 1 year. If you remember the empagliflozin, EMPA-REG study, the SGLT2, the separation starts within a couple of months, telling us that separation was more because of the effect of the drug on the vascular or in the, it was a diuretic kind of effect which was seen in that, plus the other. The effect started very early with an SGLT2, but with a GLP-1, it takes some time before the separation comes. And this tells us that probably this effect is on the basic pathophysiology of diabetes. Probably it is an anti-atherogenic agent. We need more evidence to show that. Then we had the ELISA trial, which looked at once daily lexinatide. It focused on patients with type 2 diabetes who had myocardial infarction and who had been hospitalized for unstable angina within the previous 180 days. 6,000 plus patients, median duration 25 months. In patients with a recent acute coronary syndrome, lexinatide, a short-acting GLP-1 receptor agonist, met the non-inferiority criteria. It did not show any superiority, it did not show any additional benefit, but it did not cause any problems. So there was no cardiovascular danger with the drug. Then came Harmony, which was a once-weekly albiglutide. And that again focused on CV safety. They just wanted to rule out CV safety. So it was a short trial, though the number was quite decent, 9,000 plus. 1.6 years is a very short duration for the study. Once weekly albiglutide showed beneficial effect in terms of CV outcomes. It was very surprising. They just wanted to look for CV safety and they found CV benefit. And this probably further adds to the support that the cardiovascular benefits mediated by GLP-1 receptors are not through just weight loss or blood pressure control or HbA1c reduction. There is more to it than just these parameters. So here if you see the primary endpoints, non-inferiority very significant, superiority again very significant there, fatal, non-fatal MI coming down by almost 25% in the Harmony study. Then we had this Freedom CVO. This was an ITC 650, implantable exenatide. And this is currently under investigation by the US FDA, though they have not approved this device as of November 2017. Here, what you have, it's a novel strategy of delivering exenatide in a continuous release implantable osmotic pump. It's the size of a matchstick which can be implanted, and the medication will just keep slowly dribbling out of this device over a period of 6 months and maybe even a year. So it's just one procedure and the patient is taken care of for 6 months. But Freedom, phase 3 trials were done in over 4,000 patients. Apparently they met the primary and secondary endpoints, but it has not been approved by US FDA as of today. But this Freedom study, nothing has been published about it. Nothing is there in the public domain as to what the real outcomes have been. But apparently what the US FDA felt was this was an implantable device. What if this causes a little hypoglycemia? There is a small percentage risk of hypoglycemia even with GLP-1. Though we just say offhand that it does not cause hypoglycemia, it can. So once it's implanted, then you don't have a control on it. Probably that is the reason why the US FDA has not really approved this yet. You had the Rewind trial which was presented just couple of weeks back at the ADA. Good HbA1c reduction, body weight reduction of less than about 1.5 kg. So you had a 0.61% reduction in HbA1c, very significant p-value, 1.46 kg weight loss as compared to the placebo. Cardiovascular death, non-fatal myocardial infarction, non-fatal stroke. If you look at all of them, 12% reduction in 3-point MACE, 24% reduction in non-fatal stroke. If you look at all-cause death, not much of a difference. Hazards ratio 0.9. So it's a 10% reduction in all-cause mortality, which doesn't become statistically significant. Renal composite endpoints, 30% fall in EGFR and renal replacement. There's a nice 15% reduction in renal composite endpoints for new macroalbuminuria, for progression or worsening of GFR and renal replacement therapy. Incretin, multiple effects on human physiology. We know that incretins have effects on multiple end organs in the body, brain, stomach, heart, pancreas, liver, and so on. And also on the beta cells. Look at the comparative studies for HbA1c reduction. All of them give that similar one, and here we don't have the SUSTAIN 6 and the PIONEER here to compare, but HbA1c reduction has been maximum with liraglutide. Body weight reduction, again, maximum in this group which has been shown here is with liraglutide, but semaglutide has a much greater reduction in body weight. So if you look at GLP-1 receptor agonist comparative studies, there are important differences between the GLP-1 receptor agonist molecules and their pharmacology, and the study population and the design of respective cardiovascular outcomes. So each of the studies is individual in itself. Some were done just to look for cardiovascular safety, some were to look for superiority, looked at renal outcome, and so on. But the evidence is very clear that long-acting GLP-1 receptor agonists confer a benefit on the risk of adverse CV outcomes, particularly in those patients with an established cardiovascular disease. I repeat, with an established cardiovascular disease. GLP-1 receptor agonist comparative studies, one must remember that the primary indication of a GLP-1 receptor agonist is to treat blood glucose. We are using all these drugs is basically to treat blood glucose. Let us not forget, cardiac and all this, but that is the primary thing. Additional reasons to use this therapy is in patients with or without established cardiovascular disease. Now, when you have a patient with a cardiovascular disease, you may consider this as an additional bonus when you use this drug, and the potential for weight loss and avoidance of hypoglycemia. So you have a drug which has a good cardiovascular outcome, you have a drug which will cause weight loss, you have a drug which will avoid hypoglycemia. Now these are properties which can be used along with your primary desire to bring down the blood glucose in specific circumstances, especially with cardiovascular disease. So the cardiovascular and potential renal benefits that were observed recently in the REWIND study and other cardiovascular outcome trials of GLP-1 provide yet another reason for GLP-1 receptor agonist therapy across the entire spectrum of patients with type 2 diabetes. Now, when you look at effect of GLP-1 receptor agonists that go beyond glycemic control, the next question is, are they really cardiovascular drugs? If you have a drug that is going to benefit your cardiovascular outcome, if you look like I showed you in the liraglutide study, the separation of the curves took time, suggesting an effect on the biology of atherosclerosis versus a hemodynamic effect. In SGLT2, you have a pure hemodynamic effect, which gives you the benefits right from day one of usage of that drug. Here it takes at least a year on an average to really show you that the benefits are accruing. What about adherence and persistence? The extent to which patients take the medicine prescribed by their healthcare providers is adherence. And persistence is if they continue to take the medicine. And as far as GLP-1 is concerned, acceptance by the patient, continuation by the patient is a difficult proposition. For one, it is injectable. The moment you talk of injection, the patient says, "Nako re baba," avoid injection. Next is the cost. So whenever you are looking at the persistence or continuous, you must look at the efficacy, adverse effects and the cost. It is also associated with nausea, vomiting, general feeling of ill health in patients in the initial stages at least, till they get used to it. So these are the problems that the patient face, the cost injected and the adverse effects. Now, if you look at the clinical applicability of this, if everything else is taken care of, among the GLP-1, the once weekly administration is preferred to once daily. Obviously, the patient doesn't want to take a poke once or twice daily. So, adherence is enhanced with less frequent dosage, and surveys reveal that patients use once weekly injection positively versus daily injection. Now, there was a survey done in UK and Germany on patients who were on GLP-1, and they found that after 12 months of having used it, as per the survey, 29.5 in the UK and 36.4 in German sample stopped using the GLP-1 analog. That's a very significant, almost 1/4 to 1/3 of the patients discontinued the drug for whatever reasons. What is the current place of GLP-1 receptor agonist as per the guidelines? ADA-ESD report, consensus recommends that patients with established atherosclerotic vascular disease, heart failure or CKD. When you look at patients with atherosclerotic cardiovascular disease, that is what predominates. You use either a GLP-1 receptor agonist or a SGLT2 with proven benefits, either or. If a further intensification is required, if the patient is unable to tolerate the GLP-1 and or an SGLT2, then consider adding other classes. A DPP-4 inhibitor, if the patient is not on GLP-1, basal insulin, glitazones and sulfonylureas. Now, if heart failure or CKD predominates, then preferably SGLT2 with an evidence of reducing heart failure and or CKD progression is the drug of choice. So if heart failure is the predominant finding, SGLT2 becomes a preference. If there is no heart failure, no CKD, if you have atherosclerotic cardiovascular disease which predominates, then GLP-1 would be the primary drug of choice. So, evidence of benefit with GLP-1 receptors and SGLT2 inhibitors beyond glucose lowering has not been demonstrated in patients with type 2 diabetes without atherosclerotic cardiovascular disease. Evaluate each patient's long-term goals and cardiovascular risk. Consider the cost of GLP-1 receptor and SGLT2 inhibitor. Most of our patients can't afford these, but where they can, these are wonderful drugs to use. Consider the clinical benefits of GLP-1 receptor agonist and SGLT2 in terms of weight loss, no intrinsic risk of hypoglycemia, slight blood pressure reduction, and the glycemic efficacy of the drug. Now, when you look at GLP-1 and SGLT2 to reduce CV outcomes, for those who have atherosclerotic burden, GLP-1 receptor agonist and SGLT2 with proven CV benefits are favored. And the number one GLP-1 would be a liraglutide, followed by semaglutide and so on. And among the SGLT2, empagliflozin, canagliflozin, this is as per the CANVAS study. Now we have many more studies which have come, which put them more or less at par. You could choose, and then gradually we are looking at GLP-1 as a class effect for cardiovascular benefit, and SGLT2 again as a class effect for cardiovascular benefit. For those at a higher risk for heart failure or in those with heart failure, SGLT2 with proven CV benefits is preferred. To conclude, if a patient has clinical cardiovascular disease, Example, prior myocardial infarction, stroke, peripheral vascular disease. Current data support treatment with a GLP-1 receptor and or a SGLT2 inhibitor with proven cardiovascular benefit. Evidence-based use of GLP-1 receptor agonists should be part of a comprehensive strategy to reduce the risk of CV events in patients with type 2 diabetes. Evaluate every patient's CV risk and modify treatment plans alongside. So here now what we have seen through all these studies is that GLP-1 is not, doesn't have any anti-cardiac activity. It is beneficial for cardiovascular outcome, but in atherosclerotic cardiovascular disease. As far as heart failure is considered, SGLT2 scores. As far as weight reduction is considered, SGLT2 and GLP-1 more or less compete with each other. Not much of a difference. These are two drugs today in our armamentarium to prevent, treat, manage diabetic patients with cardiovascular morbidity. Thank you very much, ladies and gentlemen.